will creatinine clearance go if you have renal problems? Up or down?
Down.
Down. Because the renal system can't clear as much through, right? So you've got a colander there that's straining things through. Your renal system's not working correctly. It can't clear as much through. Your creatinine clearance will go down. Okay, no name. Category and dollar amount.
We'll do labs for 100.
For how much?
100.
100, okay.
We ain't ballsy.
I didn't know we had no name.
The concern when a patient develops hyperkalemia. What's the complication or issue with that? Anybody have a guess on your team?
We just need like 20 more seconds. No stealing.
If they can't answer,
There's no stealing. I didn't see that. What is your answer? Anybody on that team?
Don't deal with the heart.
Be more specific.
Does this have to do with like the weights?
you know this.
You know this. You're getting close.
I think it causes cardiac arrhythmias.
What did you just say?
I said I think it causes cardiac arrhythmias. But
Okay, very good.
oh, nice.
EKG changes. So we're going to talk a lot about potassium with the renal system. That was 100. We keep a close eye on that. You're going to have to know which diuretics hang on to potassium, which diuretics waste potassium, because you're going to want to make sure that you're able to maintain, give your patient a diuretic and keep his potassium level normal for those concerns. Renal rules. Where are you? All right. Category and dollar amount. Dialysis, 400. Pre-manifestations of uremia. Your answer. There's a bunch. Okay. Okay, and one more.
Muscle cramps.
All right, you got it. There's a bunch. Why does the patient have uremia? Or what does that even mean? What number is his BUN going to be?
High.
Really high, right. Because your body produces waste products, nitrogen, waste products, that's what your BUN shows us. Whenever because those waste products get to the kidneys can't filter correctly, it's just going to keep building up in the whole serum system. You're going to have a really high BUN level, and then the patient's going to start to evidence symptoms like all of these. All right. Black cat. All of this we'll cover again when we start talking about it within the context of the class. But I won't spend as much time on it to cover it because definitely it's just a way to sort of intro it. Where are you? Okay. Category dollar amount, please.
What do we want? Nobody knows. Polycystic 200.
What did you just tell me?
PKD 200.
Polycystic for 2.
Uh-huh. I don't know.
With polycystic kidney disease, 2 expected serum lab changes, as in specific increases.
BUN and creatinine.
BUN creatinine. Again, the BUN is elevated because of the waste buildup. The creatinine is elevated because the creatinine was produced and the kidneys can't clear it through there. Very good. Okay. Is that wages? Okay. Wages. Disorders, 400. Medication that will change the color of urine.
Related to the subject or anything?
I just need one. Any yes from your team? You can give whatever you think is going to be the right answer.
I did really bad.
The last question.
Yep.
Oh, that's just three. They got it.
Those are the three. So that's good education for your patient. By the way, when you take this, your urine may change a bright fluorescent color. Don't be concerned, that's part of it. And it will permanently stain items. So if they've got stress incontinence or things like that, it may permanently stain your clothing or your sheets or whatever it might be. Okay, after the first round, we have a three-way tie. We're back up to Joe Mama. PKD for 300. The decreased blood flow activates this response, which in turn increases the blood pressure.
Renal. What is renal?
Yep. The renin-angiotensin system, we'll talk about that. That's why we give them antihypertensives. That's why we give them ACE inhibitors. That whole system keeps kicking the blood pressure up, 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 up. And Jay Booty in the clip. Oh, human fires. Oh my God. The weight of each kidney. Don't say
2.5 pounds. No. Not that one. It looks like a pound.
Any thought?
You know what I mean? Like
A pound. No, I don't think it's a pound. They're big though. They're big though. They did that.
Your guess.
That we watched. They're like huge things.
4.5 ounces.
There we go.
So each kidney only weighs 4.5 ounces.
Almost a half pound.
Okay, no name. Okay, no name.
Oh, we're gonna do the polycystic 500.
Whoa.
The complications vary aneurysm, which produces this patient's symptom.
I don't know why I picked
A
that.
complication of PKD.
Berry.
Your guess.
Tito gets.
Y'all got a little ballsy.
Anybody on your team?
I don't know.
You don't really get the dollar amounts, so if you blow it all together, it's not that big of a deal. A headache.
Yeah, that's
A headache. That's exactly right.
Oh my goodness.
Symptom of aneurysm. And I would just
severe head.
guess that as an answer for future reference. If you're talking about a patient who's got an aneurysm and I have no idea what the right answer is, that headache is on there, that would be just an educated guess I would do as a student. If you think about blood vessels at first, I would probably just guess that even if it wasn't related to this specific type of thing. Okay, rules.
Sorry about that.
We're just guessing.
That's fine.
Category and dollar amount, please. Numbers through 100. The percent of cardiac output received by the kidneys. What is 25%?
Ooh.
So therefore, when your patient has low cardiac output, because of heart failure, because of other things like that, therefore the kidneys don't get what they need as well. So a lot of times you have a big acute event in the front end, the kidneys start not producing urine on their end because they have to get 25% of what the cardiac output is. Okay, black cat.
Oh, that's us. Disorders, 300.
The most common organism in infectious cystitis.
She says streptococcus.
Oh, I think it's E. coli. What is E. coli?
E. coli.
Yes!
Because of proximity to the urinary system. E. coli is in the anal rectal area. So the proximity of that is why that's a culprit, oftentimes causes the infection in the urinary system. Wait.
That causes like a lot.
The name of the pouch used to bring the ureter onto the surface of the skin.
Whose turn is it?
Any guess?
This is the break.
Indiana pouch. So we'll talk about the urinary diversion devices and which ones the patient would need to catheterize, which ones the patient will have a stoma bag on the outside. You'll need to know the differences between those. Back up front, show mama.
Okay, the E. coli is the most common in cystitis. Most common bacteria in like a UTI.
Show mama.
Cystitis.
Thank you.
This is just a word for bladder, you know, so.
A category of antihypertensives that will likely be prescribed. A category of antihypertensives. ACE inhibitors. ACE stands for angiotensin conversion enzyme. So it stops that whole conversion process that keeps that blood pressure too high for that renal patient. And that's why that's a great choice of medications for that patient. Those will be meds you'll need to know. We'll go through those.
Come on, Jay Booty.
Jay Booty in the clip. See if we can get you on the board. And you two have been fired down to the other four. No, it's not. Someone has chosen.
That was us.
The normal BUN. And which way would the BUN go for the renal patient? Because of waste getting milk out of the correct. And it's called BUN, it's not called buns. Don't type in normal, good looking buns. Yeah, there you go. Well, that's why I get spam
We
on
don't
mine.
have 300?
Okay,
We have two.
where are you in what category and dollar amount?
Where are we?
Can we have this?
We got the first one too.
Journey.
3 hormonal functions of the kidneys.
Our
There are
numbers
5
were-
altogether.
They filter the waste, blood pressure, and
Like 400.
Oh, okay, this got one. You say it.
So we have a total of like 500. She's got
when
like
in
300.
production.
She said we only have to say 30.
Oh, okay.
You were right with your Ren. The other ones are these functions. And we'll talk about the hormones, we'll talk about their functions.
Okay, I'll do that one.
No, I don't know.
The average GFR for a patient age 65 and over. 65. So their GFR is about half of yours as a younger person. Therefore, we worry about giving them nephrotoxic meds, by giving them contrast, all the things that we may stress their kidneys out. Because they only filter half of what you all filter. 500 like that.
Okay, but first, we got our first one right also, and it was 200.
What's that? Do you need to have money added to yours?
Oh yeah, it's supposed to be 5.
Supposed to have been 5.
Because we got two
We got
questions.
200 and then 300. Oh yeah. Gotta fix that.
Well, ours is supposed to be 1,000. We're supposed to have more.
We'll do patient dialysis for 300.
What?
Patient dialysis 300.
The most common cause of peritonitis. Any thought about that?
It's the inside dialysis. What the hell?
What?
It's not though.
What?
Say it. Just say
I
it.
don't know.
What is the internal dialysis? Yeah, we don't know the name of it.
The most common cause of peritonitis is when the site is contaminated. Peritoneal dialysis goes through a catheter that goes in the peritoneum, and it's the patient, family, caregiver, whoever's doing the dialysis for them, contamination when they're hooking that tubing up to the patient's catheter.
Yeah.
Because it's often done in a home environment, which creates a lot of other infection control risks. No.
It's like just
Wait.
improper, like taking. I think we're taking.
The number of milliliters per minute of blood flow received by the kidneys. That's how many milliliters your kidneys have to process every minute of your entire life. Which is a bunch. Okay, last round. Yo mama.
Last one, my friend.
The normal adult GFR.
Greater or equal to 9.
I need a range.
Oh, range.
I don't know. We'll have Jeremy do the Here's the right answer, Jeremy. You can decide.
Greater than 9. And then 90 to 120.
Oh, he's got it.
Mine
They
don't.
weren't
I said 130.
They don't
No,
get that.
that was too low.
Okay.
She said it like 5
Nobody argues with Ken Jennings, judge on the Jeopardy, so we're gonna go with Jeremy. What is GFR? What does that even mean?
Glomerular.
I know that.
The washing machine. The washing machine.
How much your kidneys are filtering every minute? So how well is your colander or your strainer working? Different than creatinine clearance. GFR is all of it. That's the writing of the kidneys. How will this number go? Up or down when you have renal problems? Down. Just keep always thinking that it's not straining correctly, especially building up in the serum, and the clearances will be decreased, correct? Okay, Shay, Booty, and Clay. In the hospital setting, the most common factor placing patients at risk for UTIs. 200, yes. No, maybe.
Renals are danger. We should have disorders or something. We might have to. Is there one? There's only some 100s and a 200 left.
Not in disorder. Oh, that's what it's called?
The ones that are in right?
Oh, we already did.
Hey,
Oh,
Shotty.
we want patient dialysis 200.
Oh, okay, yeah, you're right.
The terminology or process when toxins move from an area of higher concentration to an area of lower concentration. Pardon me?
I don't know. I'm just guessing.
You're allowed to guess.
Go to the test. Proceed.
Say it.
I want to say it's hypertonic.
Anybody else on your team?
It's like, it starts with
What is diffusion? That's the
Wait, what?
process. I know it's gonna get, since you probably have that in.
Because it's a toxin instead.
You know,
Renal
6
rules.
points is better than 0.
Who's re- oh, wait.
The length of the kidneys.
Yeah,
It's all relevant.
6 inches.
but are we gonna be asked this?
No, but the realization that we've got these kidneys that don't weigh very much, that do a lot. Inches. So we got this 4.5 ounce kidney that only is about 4 to 5 inches long. That's expected to do all this work. Black cat.
PKD 100.
The complication that will occur if the cyst rupture. What?
If the cyst rupture,
Complication.
hyper,
What is infection and pain?
Yes, the answer is bleeding or increased blood pressure.
so we didn't get.
Okay, wages. The urgent need to void regardless of the volume of urine in the bladder. It's called what?
But that's right there. It says urgent. It's something urea. It's not this urea. It's molecule. That means not
Urgent comments. So it looks like the renal rules did rule today. You guys get mints because your knowledge is worth a mint. So cheesy. Okay. I know, that's why I said, I'm like, Thank you, Jeremy, for helping with scorekeeping. Happy birthday early. Okay, we'll get started.
Where'd you get your shirt?
Huh?
Where'd you get your shirt? Is that a bingo shirt?
No, so this is
thought it
cold
said
water.
bingo.
I got coffee all over me.
Oh, I thought it said bingo. It's cute.
Have a lie. Cavalier. Cold
Oh,
water.
Cavaliers.
Have a
You're Cleveland Cavs fan? Are you a Cavs fan?
No, I live in Coldwater.
Okay.
In the Coldwater Cavaliers.
Oh, okay. I
But
didn't
it's
know.
in the red.
I thought it was the Cincinnati.
It is, you're right.
I'm so glad you came back here.
Thank you.
Yeah, at least we got pictures.
What happened? Okay, child. Yes, I was doing my homework and I brought I gotta eat it back.
Thank you.
I don't know why I was thinking hypervolemia. It would be hypovolemia, right? If they're bleeding.
But it made their, well, that would be why they had hypertension then, because if it went
Would it
down,
be
then they were.
hypervolemia or hypovolemia? When you're bleeding, oh, but you're not bleeding, you're staying, so hypovolemia.
I have
I was trying to say bleeding, but I don't know.
I know nothing about it. All the stuff we learned. I'm pretty much clueless when it comes to that. Yeah, I haven't learned video stuff.
Okay, we'll get started with renal. Might as well start out with something here, right?
Famous kidneys, Nicole Kidney, Billy the Kidney. Hello Kidney. That's funny. Kidney Rock. The
John
Kidney
F.
and
Kidney.
John F. Kidney.
No, you don't need to know how much it weighs or how long it is, but it is important to realize always that we need to maintain really good kidney renal health for you all and for your patients. Because that little bitty kidney is doing a lot of work. As I said, the kidney receives about 25% of your cardiac output. Blood circulates through the kidneys about 12 times per hour. So your patient's not getting enough cardiac output, your renal system will pay a price for that. Renal threshold, as we talked about, anybody have questions about that after we talked about it during Jeopardy? That is not a lab value, that's the average amount of glucose that your kidneys can handle. Glucose should not be in the urine. If it shows up in the urine, you have a prediction or a guess or a thought that I bet your serum glucose level is elevated because it's spilling over into your urine. Protein should not be in the urine either. So you're evaluating your patient's urinalysis. You know which abnormal findings. That's just a thought I just made up at the top of my head, but that's a thought. We'll go through conditions where protein does show up in the urine. It means that the filtering system is not working correctly. The holes in your colander are too big and it's allowing the protein to get through to the urine. So your analysis tells us a lot. Your patient comes into the office where you're working, you're a nurse practitioner or wherever you're working, and they present with symptoms. I would always say, let's just do a urinalysis while you're in here, because it may tell us something that you've got going on, even if they don't really present with renal problems. There's the blood flow through the kidneys. Again, you don't need to know that number, but it's a lot to think about, right? A little 4.5 ounce kidney is processing over 1,000 milliliters a minute of blood flow. One of the processes within the renal system is producing or managing, altering, compensating for the hormone of antidiuretic hormones. Your patient's dehydrated, your renal system kicks in, says let's hang on to more fluid, increases the antidiuretic hormone to try to compensate for that and to try to hang on to more fluid, and vice versa. If you have a state of dehydration, you will have a high specific gravity. And that will tell you that that's what kind of condition your patient is in. So it's a great compensatory mechanism that your renal system does. So if you all are dehydrated, if you've got normal working kidneys, it'll say, I need to hang on to more antidiuretic hormone. I need to help them so they don't diurese as much, that I can get that fluid back up. Osmolality, now you don't have to spell it correctly. It reflects the kidney's ability to concentrate urine or to dilute urine. So for these values, I'm trying to go through the values that you would need to know. I would put osmolality on your list. There is a difference, you don't need to know this slide, but there is a difference between osmolality, osmolality, and I'm the same word, but you don't need to worry about that. So osmolality tells us again, ability to dilute or concentrate the urine. Dilute urine increases the osmolality. And vice versa. Specific gravity will tell us what's going on also related to dehydration or too much fluid, dehydration causes you to have increased specific gravity. Know the normal for that as well.
I have a question. Why is this one saying the normal is like the higher, like normal 1.125, but only for about like 1.0?
That's a good question, and as we recognize, all across the board, you'll find different ranges of normals. And I just wish life would be simple and easy, but when you look it up why that's the case, there's lots of things that play into that. So that's a great question. If you have a different normal on your notes, in your brain, if I give you a number, it'll be above the highest normal that we know. So if I give you a number, good question, it'll be above 1.030. Enough above that you'll recognize that it's definitely high or definitely low. Because as I said, there are different normal values depending on where you work, what system you use, what lab uses, and on and on and on. To make it a little bit more complicated for you all. Monitoring weight, as you already talked about, the cardiac system. Tell your patient to weigh themselves every day, same time of day, same scale, same clothing. And just as a fun fact, 1 pound of weight gain equals approximately 500 milliliters of fluid gain. So I want you to record your weight every day. Write that down, write that down. I want you to let me know if you notice that every day, or each day that you are increasing your weight, especially if you're a renal patient. Aldosterone is produced by the adrenal glands. ALD, adrenals. It regulates your blood pressure. Your renal system does a lot to regulate your blood pressure as well. That's where we just talked about that. This is important to know. Your renin is your hormone produced by your kidneys. It was what regulates your blood pressure. So you come in as a normal patient with normal renal system, kidney function, and you have a state of low blood pressure because you're in a state of some kind of whatever it is that you have. Your renin system kicks in, does the whole conversion process that's on this little picture, and it says, you know what, I need to get your blood pressure back up. It increases your blood pressure, gets you back to normal, which is great, which is what it's supposed to do. The problem when you have renal dysfunction is that the renin doesn't function correctly, and it keeps that patient always in a constant state of high blood pressure because of this whole renin mess up. For you, normal, that's good. The renin's doing what it's supposed to do. For this renal patient, it keeps them hypertensive. Creatinine clearance. For your patients, your inpatients, they will do an estimated creatinine clearance. Ideally, if we wanted to know how much creatinine your renal system is clearing, we would collect your urine for a certain period of time, and then we would know exactly how much creatinine your renal system is clearing, your kidneys are clearing. For our patients, we always want to do an estimate, and there's an equation that will give us an estimate. You don't need to know the equation. But on your chart, oftentimes you will see an estimated creatinine clearance for all of your patients, inpatients. Because that will tell us how the renal system is working or not working. Should we give that patient nephrotoxic meds? Should we give them some pretty strong antibiotics, or their kidneys too stressed out that they can't handle it? So in red, or wine, whatever that color is, this is the most important approximation of renal function. That's why we run those numbers on our patients. So pay attention to that number, even if they're not in for a renal problem. We want to pay attention to that. You're sending them in for a contrast procedure. You're giving them medication. You're giving them chemo. Can your kidneys handle what you're presenting to the kidneys today? So that's an important number to keep track of. Which way will this go when you have renal problems? Down. Can't clear as much, correct. That's different than GFR as we talked about. You also may see estimated GFR listed in your chart. That's calculated based on that equation. You don't need to know that equation. But that tells us overall, how is the colander or strainer doing? That includes everything. The last one included only just the creatinine, because that's the best indicator of kidney function. This one includes everything that's arriving at the colander, how well is it straining and filtering and doing all of what it's supposed to do. And again, you don't have to memorize that equation unless you like to for fun in your spare time. I know you all have a lot of it right now. Erythropoietin, that's a big deal. That's a hormone that gets produced by the kidneys as well. Poor kidney function, which way will this go? Down. Correct. You can't produce it adequately. How do you know that? You're going to have, this is what's responsible for your red blood cells. So, renal dysfunction, decreased erythropoietin production, decreased hemoglobin, and that's what you find that goes with your patients. So, highly likely that in a couple of weeks, your patient that presents with kidney issues, you'll be expected to know which way their labs will go. You have a patient that's in here, you're taking care of him, he's got chronic renal failure, which lab findings do you expect to see? And if you answer that, saying I'm expecting to see a low hemoglobin, that tells me that you know that the kidneys produce erythropoietin, you know with kidney problems it's going to be decreased production, therefore you know that the red blood cells will probably be decreased. Red blood cells will be decreased, so will hemoglobin. We'll talk more about that when we get to hematology next week. Again, the kidneys normally excrete the wastes that need to be excreted to keep you in good balance. So your BUN will go which direction when you have a patient with kidney problems? Up. If you don't understand the whole increased serum numbers, decreased clearance numbers, we can talk about that one-on-one and I can explain it more. It's important to think, okay, it keeps getting produced in the serum, but when it arrives at the strainer, it doesn't get strained through, so it keeps getting produced in the serum. So the BUN will go up. Like I said earlier, don't type in BUN, or when you report off a number, we don't typically say, well, their BUN is 30. We just call it BUN. That's just the terminology that gets used. You're not expected to know this. We covered neuro a couple weeks ago, but there are, depending on where the spinal cord injury is, will depend on how well they can do with either maintaining urine, voiding on their own, all those things. It just depends on what level things occur at as to what they can or cannot do from that standpoint. Older patients, as we said already, can't filter as well. They filter probably about half of what you filter. So therefore, we get really concerned when they're older age is one risk factor, and then we're expecting your kidneys to manage all kind of heavy duty meds. So always take that into consideration. If you're given a test question and we're giving you an age, that should factor into your processing and thinking through that. Why do they tell me that she's 50? Why do they tell me that she's 70? If you say that older people are anybody under the age of 65, you've lost 25 points on that test question. I'm just telling you. I know who you are and where to find you. Renal bruits, we don't typically auscultate for them. That's abnormal. If a bruit is noted, you don't need to know the slide. You do if you have a renal patient, you won't need to know it for the next couple weeks. Specific gravity, we already talked about that. That's a urine test. Serum creatinine in capital, and bold, and red. The only thing that causes you to have an elevated serum creatinine are renal problems. There's no other body system that's going to cause you to have renal and increased creatinine. So creatinine is a number to watch out for your patients, always. There's the normal. Which way will it go when you have renal problems? Up, correct. And the estimate is that you don't really have an elevated serum creatinine until about 50% of your kidney function is lost. So that's concerning when we see a serum creatinine of 2. Like, oh, yikes, there's some renal problems going on here. That's a number to keep track of always as a patient caregiver. That tells us a lot about that. The only body system that causes you to have a change in your serum creatinine or elevated serum creatinine is your renal. Lots of tests, but I'm not gonna go through these in details. We can do lots of things if we're suspecting renal issues going on. When you are giving someone contrast, it's super important that you know what their kidney function is. Because contrast is hard for the kidneys to process and get rid of. So, if we suspect that you have renal issues to begin with, or you're at risk, or even if you're not, we almost always do renal function tests before we send you in for that cardiac cath or for that angiogram that's going to run dye through your system. We want to make sure that your kidneys can get rid of the dye afterwards. You know, we're not going to stress your kidneys out too much. We also will do a good med profile. These meds that are listed here are pretty nephrotoxic. So, you have a 70-year-old you want to do a contrast procedure with, and that 70-year-old, that's a risk factor, first of all, and she says, well, I take an NSAID every 4 hours for my arthritis. Well, that's another risk factor. Let's do some really good renal function tests to make sure that we're not going to stress your kidneys out as a result of this procedure. And if we are, maybe we need to consider, is there a different diagnostic test we can do? Otherwise, you may send that patient into acute kidney injury following the procedure because the kidneys now are also stressed out because they're trying to get rid of your contrast. In red and bold are the things, definite criteria that we use. So, given a patient profile, given lab results, and you see that the serum creatinine level is above 1.5, really call and give consideration whether that contrast procedure is necessary or not. Pay attention to the stuff in red, more so than the little bitty detail stuff, not little bitty detail stuff. But if you're asked this in a couple of weeks, this will be the number to watch out for. So your patient is scheduled for a cardiac cath tomorrow. This is the patient's profile. What risk factors does she have, or which one of these findings warrants contacting the healthcare provider? If you see that elevated serum creatinine number, that's the answer. Also important to know, if your patient takes glucophage, which is metformin, we tell them to hold that metformin before the procedure for at least 24 hours. Afterwards, I don't want you taking your metformin for at least 48 hours, and I don't want you resuming that until we've checked your kidney function test. That's the patient teaching that will need to go with that. For any contrast procedure. Yes. 24 before, at least 48 hours afterwards. You're sending your patient home after following your renal angiogram, and you see that she takes metformin. What patient teaching will go with that? Well, you need to not resume your metformin for at least 48 hours. Today is Wednesday, so at least need to hold on, not take it until Friday. And I want you coming in on Friday afternoon, and I want to run some renal function tests, and then if they're good, then you can resume it on Saturday. Or Friday, or whatever, however that works out. But that's how that conversation teaching could go. Again, in red and bold, last several slides, check kidney function for at-risk patients. We can do endoscopies. We've talked about scopes and other avenues. Kidney biopsy, if you're doing that, they're very vascular. The normal concerns you have for post-procedural bleeding, which we've been talking about all along. Check for hemoglobin, check for dizziness. I know it hurts, but I'm going to have to look at your backside. Don't rely on what's on the med sheet. If they've got bleeding or something else going on externally, I need to really look underneath you and make sure there's nothing going on or anything like that. Post-biopsy, their urine may contain blood for a period of time, just because it's been traumatized, but it should clear in the next day or so. Yes, because Yes. Under the abdomen, because if I'm having you recover from your post-op, I'll probably have you in the prone position, and then we put a sandbag on the abdomen, keep that kidney elevated. That's the thing there. Good question. Okay, we're gonna take a break. What questions do you think are most, or what content is most important from what we covered within the PowerPoint?
Lab values.
Absolutely, the lab values. And they always go the same direction when we have renal patients. So unlike cardiac, where sometimes it's up, sometimes it's down, that's not the case here. So without looking at your notes, which way will the serum creatinine level go?
Up.
Which way will the creatinine clearance go?
Down.
Correct, and that's directly correlation, right? It keeps getting produced, you can't get it cleared. Which way will the GFR go? Down.
Oh, shit.
How about the hemoglobin?
Up.
Down.
Down, because what gets produced by the kidneys? Erythropoietin, and that's responsible for your red blood cells. And if you have decreased erythropoietin production because you don't have your kidneys working correctly, therefore your hemoglobin and your red blood cells will go down. What about blood pressure? Up, because the whole renin system's messed up correctly. Serum BUN, up. Serum creatinine, we recover that, yep. GFR, answer that. So, which way will your specific gravity go if your patient's dehydrated? Up, correct. So all of those are important to know, to understand physiologically why they're changing the way, the direction they're going. There will be questions throughout your patient care that you're going to want to keep an eye on that whole renal system, what are the kidneys doing. So therefore, those labs should be really easy for you to figure out for sure which direction goes what and that you're monitoring all of those. Contrast procedural, teaching, monitoring the patient, all of that. Check kidney functions before, after, could you identify risk factors given that. Patient teaching about metformin after contrast procedure, absolutely. Kidneys are vascular, post-procedural, you got some kidney invasive procedures. Anybody else have another
hard to
thought
get it to
or
come.
questions about what we've covered?
We kind of flew over that urologic endoscopy. We don't need that.
No,
It's like,
you've been knowing about scopes all along, so. Any other questions about that? Okay, I've got 12 after on this clock, and if you want to take a break until about 22 after.